Welcome back to the Blueprint to Ultra podcast with your hosts, Steve Epifano and Jeff Winchester. Listen, we are excited to have you today. Our goal with this podcast is to help you put together your own personal blueprint to running ultras. And we do that by interviewing a variety of guests, those from the back of the pack all the way to the front of the pack. However, sometimes we bring in a special guest to talk about topics that we think impact every single runner. And so today is no exception. Our guest today is a doctor of chiropractic medicine with an emphasis in sports medicine. She is a running endurance specialist at Performance Place Sports Care over on the West Coast. Very close, apparently, to where Steve lives. The two of them were discussing that before the show. And most importantly for this audience, someone who truly understands runners because she is also one herself. According to her background info that she shared with us, her running journey actually started by accident. It was a mistake to some degree. She joined the cross-country team at Long Beach Poly just to stay in shape for soccer. Her better love, Steve, I guess.
In theory.
Even though we prefer runners, only to discover she was a much better runner than soccer player. And as we get older, most of us feel the same. From there, she went on to compete in cross country and track at UC Davis. But today, we're not really going to talk about her running experiences, even though she has done an ultra or two. She's actually done 250Ks and 100K. Today, we're diving, though, into 5 of the most common injuries that runners and ultra runners kind of experience. And those 5 are, so if you're listening, you're like, maybe I should listen, maybe I shouldn't listen. If you've had any of these 5, these are what we're talking about. Plantar fasciitis, IT band syndrome, patellar tendinopathy, also known as runner's knee because it sounded way too scientific, low back pain, and Achilles tendinitis. We'll talk about why these injuries happen, how runners can treat them, and most importantly, how to prevent them before they get ready for the next big race. So do me a favor as my headset falls out of my ear. Sorry, everybody. I would say this sounds like a great conversation, though, for everybody. So without further delay, join me in welcoming Dr. Mandy Wainfan into the show. Dr. Mandy, can I call you Mandy?
Yeah, totally. That's what everyone, patients included, call me. So
fantastic. Well, Mandy, welcome to the show. We're excited to have you.
Yeah, excited to be here.
Sorry about that random introduction. I was a little bit all over the board. But so before we get into the topic of those common injuries that we kind of listed off just a second ago, we do want to learn a little bit about yourself because this is a running podcast. I may have kind of shocked some people in saying we're going to talk about injuries, which they will possibly experience or they have. But they also like to know that our guest has a little bit of running background because it makes you more relatable to them. So how did you get into trail running and eventually even into experiencing ultra running?
Yeah. So like you mentioned, I ran in the NCAA, did cross country and track through high school and college, which was a lot of fun. I'd go back and do it again if I had the choice. But I wanted to continue my track career after college. I had like unfinished business in the 1500. So over the summer after I graduated undergrad, a couple friends of mine were like, hey, come do your long run with us. We're not going to tell you how long. Just come and drive out and we'll do the loop. The loop ended up being 15 miles out in the San Gabriel Mountains just out from LA. I'd never been there before, so I was, totally new to it. Thought 2K avert was like impossible, and I was, lactic acid headache and everything. Now it's like, oh wow. But yeah, so we did that loop, and that was the start of everything. From then I was hooked, and they took me on plenty of adventures in the next summer. One of them now is my now fiance. We're getting married in a month. So.
Oh, wow. Wait, pause.
Yeah.
Congratulations.
Thank you.
So you met your fiance trail running.
Yeah. He and one of our mutual friends, we'd all known of each other. We all attended the same high school and ran cross country at different times. And so kind of coalesced. This was during COVID, so you could only run with a few people kind of apart. And yeah, so it was a weird, we would have met at some point, but it ended up being through trail running.
So another reason people should, participate in trail running is if you're single and you want to find somebody, this is the reason, right?
Yeah, find your local trail runners. And yeah, especially the women, there's a lot more men. So.
Wow.
But yeah.
Free nuggets here. Let's go.
But yeah, so they took me on this loop, and that was in the winter of 2020, and then the whole summer of 2021, I did a trail race in May up in Bishop, California, and it snowballed really fast. So they had been up in the Eastern Sierra doing, crazy stuff, and same kind of thing. They're like, "Hey, just come with us. Here's a pretty photo. Don't you want to see this?" I was like, "Yeah, that sounds great. How hard is it?" And they're like, "Don't worry about it. We'll drive you up there." So did a ton of scrambling, like huge days out there, and it was like totally history since then.
That's fantastic. And you then did ultra running. How did you end up in an ultra race in the first place?
Yeah, so the friend who's not my fiance, he is a total badass 100-miler. He's one of those guys that's like, cotton t-shirt and fanny pack for a while. He's my age, but brought up by the OGs, so to speak. Had been ultra running at that point. He started in college, quit his NCAA team, ran Zion 100, I don't know, within the year, did super well. So he told me about it, and I'd actually never heard of ultra running before that. I knew people I'd heard of somebody doing 100-mile thing. I didn't know it was a race. It just sounded like somebody decided to go do some crazy shit out in the woods. But yeah, so he told me about it, and my now fiance, Eric, had done a few ultras before that. So sometime in the summer during all of that crazy trail running, I signed up for Black Canyon. It was actually a 60K at the time. And I've heard they changed it now to a 50K, but yeah, so it was a fairly easy transition from like road and track running to trail running, since it's a little more analogous. Now I do more of the steep stuff and the more adventure runs. I hop in races, but mostly just big stuff out in the Eastern Sierra.
Well, I did see that you did a 100K in 2024. I think it's called the
Cuyamaca.
What is it called?
Yeah,
Cuyamaca. Yeah, I saw it on the sign. I was like, I don't even know what it said. It was so many letters.
No, that race is so great. It's like, the people running the aid stations have been doing it forever. They all have themes and stuff. It's a local race, but it draws a really cool crowd, like folks who have been doing it for a decade plus. I loved it.
I think it's a Western States qualifier too, Jeff.
Is it really?
Yeah.
Yep.
Yeah, I learned that during the race. I was running with some women, and they're like, "Oh, you going for the qualifier?" I'm like, "For states?" I didn't even know. But
Sure.
It's not a golden ticket race, but yeah, apparently it was. So
you get a ticket in a lottery. So yes, Mandy, most of us don't get a golden ticket from these races. We just get a regular old boring lottery ticket. And
I have a whole one ticket, to my name. Now that they've changed the rules,
apparently it only takes one to get in.
One of my good friends, she got in a couple of years ago after 7 years.
Yep.
So she every single year watching the lottery. Yep.
That's where I'm at. It'll be this year. I think it'll be year 6 or year 7 for myself. I'll be trying to get in. So it's exciting though.
We'll see it. Yeah.
One day. All right. So before we get into the topics though, we have a couple general questions for you.
Sure.
Because we want to talk about injuries. We do think I think it's an issue that every runner deals with. Not that every runner will be injured, but every runner has a tweak, an ache, a pain or something. And they're not sure what's going on. So there are 5 common ones. We're going to get into them like I mentioned in the introduction. But the first question that we had for you is, in your professional experience and opinion, are ultra runners generally good patients or terrible ones?
Honestly, good.
But you're laughing.
If you have somebody who understands the sport.
Yep.
So ultra runners will do their rehab. They will do it every single day. They will overdo it.
That's the thing.
Okay.
Yeah.
That is our problem.
They're like, oh, 5x5 deadlifts. Let me do 10x5 instead, right? So that part's great, and they're super committed to it. And to me, I am glad that they're motivated to still train, even if they're in pain. There's a kind of controversial opinion. I think you can train through most things. Having folks on the other side that aren't necessarily runners, they have a pain and they get scared and they back off of everything. Mm-hmm. And that puts them in a harder spot, because then you're in this deep hole of deconditioning and now you have to climb all the way out. It's actually better for the ultra runners that are continuing to train. It's like, great, we got to build up some stuff, but you're not starting from zero. So I love it. I'm also biased, right? I do it. Yeah. So I'm, yammering about whatever race that we've both done or looking forward to. So personally.
It does make me laugh though, Steve, because when she said that we tend to do more than we're supposed to, I was like,
that's it. Yeah. I mean, as coaches, that's like, I don't know, probably 90% of our job is to make sure that they're not doing too much.
Right. Yeah. I mean, so I coached high school cross country, a little different, but there's always a few kids, the varsity kids, who are adding doubles in. I'm like, stop, calm down. You can do that, when you're an adult and you have an adult coach who tell you what to do and all that.
A little
That's
is
right.
good. A lot's got to be better.
Yep. Unless you fall into reds and then you're injured and you end up in my office.
And one more thing before we get into to the actual topics, as we were talking about this, so Brooklyn does our social media. She helps us with the podcast and prep. She is one of our content managers, if you will. So between myself, Steve, and Brooklyn, we take all of our notes and take all of our thoughts about our guest, and we're like, okay, what do we want to kind of dig into? Mm-hmm. And we kind of collectively started with this question. It's like, I've never personally gone to see a chiropractor for sports medicine or anything like that. I've only gone to see a chiropractor for back issues and stuff like that, or because I had a sciatic and things of that nature that kind of caused me to have a back issue. But we realized, we're like, well, wait a minute, we need to kind of back up just a tad, because we need to help people understand, why would you go see a chiropractor versus a PT? Because most people see a PT, that's what they're used to seeing. So if you could help unpack, like, why would a runner consider going to see somebody who does specialize in sports medicine from the chiropractic field versus PT, and where the differences would be?
Yeah, so that's a great question. There is a bit of a schism in chiropractic. So this makes it hard to just, look up online, hey, I'm an injured runner and I want to see a chiropractor. What do I do? The schism is from what we would call straight chiropractors, which are your traditional, I'm going to crack your back, I might crack your neck and do all that, and then you're going to get out of the door, versus the more sports-oriented chiropractors that, frankly, are mostly rehab-based. So I do very little actual cracking, so to speak. I'd say maybe 20% of my patients, maybe. Wow. The reason I went into chiropractic versus PT or athletic training is my scope of practice is larger. So I can diagnose. I don't have to go through a primary care in order for patients to see me. I can order imaging, all of that. So it gives me a little bit more freedom. People mistakenly call me a PT. I'm not a PT, but it looks very similar. So PTs, obviously, they have kind of the stronghold on the musculoskeletal world, as they should. But there is a small enclave of chiropractors that are doing very similar things, and that's where I'm at.
Super helpful. Yeah, because so my son is in PT school, so that's what got my attention. Is like, because he also looked at osteopathic medicine as an option as well. And so I was like, this all seems to start dovetailing a little bit to one another. So thank you for the explanation, because if somebody is impressed by what you have to say and we get into this, they're like, I need to go see Mandy, which Steve lives right around the corner from me. I already know he's going to try to figure out how to do this. But if they are interested in saying, well, maybe I need to find a chiropractor, that is the normal thing. Is we see a billboard with a spine and we're thinking they're going to do a back crack and that kind of thing. But to know that there is this smaller niche area of chiropractic medicine that focuses on this is super helpful. And so people can look for that specifically. So
yeah. A lot of those folks, myself included, do obviously the in-person stuff, but a lot of virtual. So I actually have a lot of telehealth and folks that I coach for strength training that have been through injuries, which people don't even know about. Like, I've called chiropractic boards in other states, been like, hey, I'm doing telehealth rehab stuff. And they're like, how can you do that over?
Right.
But people in my little niche do that. So it is actually a lot easier for folks, like, say, in Idaho, to find somebody like this when they may not have someone local.
Well, and before we get on to these five, actually, it's a really good point. So, and I generally will try to say this at the very end of the episode, and if I forget, or if the listener decides that they're not going to listen to all five of these, I'm going to say it now, is that you can go to your website. Again, they can look up Performance Place Sports Care. You have a website. You have a YouTube channel, has over 200,000 subscribers. You guys put out a lot of great content that people can look into as well. And so you do practice some work online. And so what I would encourage those who maybe even become very interested in what you say today is that there are you and there's several other professionals with your clinic, if you will, that they can reach out to. And so I would say, check you out, look you up online, and you can get more information. So if you can't find somebody local, you can find somebody that is virtual, and you guys would provide that as well. So top 5 most common injuries that runners deal with. Let's get into it. Steve, are you ready?
I'm always ready, man.
We're going to start with your highest level of expertise.
Okay.
Fasciitis.
Yes.
Because you wrote an actual ebook on this topic.
Yes. Yeah. And this is everywhere.
This is your wheelhouse, if you will. Like I said, we're going to add links for all these at the end of this. But for those who've never experienced it, I have experienced it and carried it for over a year.
Oh, wow.
Okay, right.
Okay.
So everybody for it. First, for those who've never experienced this and only have heard horror stories, what is it? How does it happen? Why? On why? On why? God's green earth. Why does plantar fasciitis exist?
I work at a running shop. I work at Fleet Feet in Laguna Niguel, and I would say probably half to like 60% of the people that come in, they say, I need a shoe because I got diagnosed with plantar fasciitis. So what can I do?
Half?
Yeah, we have so many comfort customers, we call them, or pain management customers that come in with heel or plantar fasciitis pain.
Yeah.
All right, man, your turn, Mandy. I'm just gonna stop.
I've had it too. Right. I've experienced it on and off. It can be tricky or it can be very simple. I've found that it's more commonly very simple if you get the diagnosis right, because there's two categories of it. There is true plantar fasciitis. So your plantar fascia is at the bottom of your foot. It's this big band of not very stretchy material, kind of think like a ligament, but flatter and usually longer. And fasciitis, itis means inflammation. So often the true plantar fasciitis, the injury is in the plantar fascia. And that's little micro tears, or it might be tearing off a little chunk of the heel bone where it attaches into the bone, which, sounds super scary. It's not fun to experience, I'll tell you that. But that's true plantar fasciitis. And then there's also false or fake or pseudo plantar fasciitis. This is more actually the majority of patients that I see. It can be confused for it, but it's actually a nerve-mediated problem, and we'll get into what that means. Also sounds scary. It's actually way easier to deal with than true plantar fasciitis. There's two differences and the symptoms overlap. So
you say we're going to get into it. Could you go ahead and get into that now? Because I don't know what you're talking about.
Please.
Because I don't know if I had fake one or real one, but it felt very, very real.
No, it's real internally.
Just a big one, Jeff.
It broke my heart.
Just think about it real hard and it'll go away. So they feel really similar. This is where people get tripped up. So both the true and the false, it's like first step out of bed, it feels like you stepped on a sharp rock, and then it'll usually warm up after 5, 10, 20 minutes. And then it starts differentiating themselves from there. So for true plantar fasciitis, it's like, okay, I really just can't walk. Like, it's really sharp. Something happened. So I stepped down really hard in a race and something tore. You will know. You'll be on crutches. The fake one, the nerve-mediated, it move around a little bit. So it might not always be at the bottom of the heel. It might be like towards the arch, or actually starting to go back towards the back of your heel or up your Achilles. I get people who are like, I have plantar fasciitis and Achilles and FHL and post-tib stuff. Like, whoa.
I'm overwhelmed.
Yeah. But this is more, the fake version is more commonly the chronic cases. So a year, if you were trying the standard, like, towel scrunches and get the Hokas and the OFOs and the, roll my foot with the frozen water bottle.
Keep going.
If that doesn't help, if you're treating it as a fasciitis and all of the fasciitis treatment doesn't help, it's probably not fasciitis.
I found I won't make this about me.
No. What'd you find?
So I did everything. Give
me the list.
I did everything you said. I did all the exercises you can come up with, all the toe exercises, all the toe yoga that you can do. I did Strasbourg sock. I did the roll in the ball. I did a tennis ball. I did a lacrosse ball. I did a frozen water bottle, because all these are different options you can try. I heard you can sleep with shoes. I never tried sleeping with shoes because my wife killed me. So I did not do that one. But I did acupuncture. I did e-stim. I went and did foot massage, like true foot massage. I did whatever they call that little scraping tool. They also scrape those. Well. Yep, I did it.
Yeah.
The Graston method, right? I did that as well. The only thing that worked, the only thing that started giving me actual relief, is I found a YouTube video that said, when you do your calf stretches, instead of just holding for 20 to 30 seconds, hold it for 2 minutes.
Yeah.
And I started holding them for 2 minutes, both two different types of calf stretches to stretch both calf muscles. 2 minutes back to back, every morning and every night. And I started getting relief. And I did start wearing Hoka Cliftons because that was the only shoe I can do with the right heel drop for me. We'll talk about that in a minute. And I also wore UFUs.
Yep. Check marks on everything. That's amazing.
I never.
Yep. I'm in the same boat. But, it's funny you mentioned the calf stretch, because that is one of the few in the Venn diagram that can help either the true or the false.
But only if you hold it for a full period of time.
Yes. So little stretches don't really do much.
It's a waste of your time. Mm-hmm. You have to go longer than you think is normal.
Yeah.
But again, that stretch, and you're supposed to be teaching me this. You're supposed to be, because the listeners are like, oh God, he needs to stay in his lane. But my personal experience is that to do that, you have to hold that stretch, but you don't overstretch.
Yes.
When they say gentle stretch, right? The gentle to mild stretch, you don't overstretch it. Most people are like, as an ultrarunner, let's see if I can't rip my Achilles rump at the same time.
More is more. Yeah.
All right. Let's pause.
Go for it.
Let me pause for a second, because I have taken over the conversation. And Steve, you should shoot me for that. Our questions, we still have a few for this. Is this a load issue or mobility issue? Is it a footwear issue?
Yeah.
Is it a myth?
It's not a myth. It is true. It exists. Load can be an aspect. So load meaning not necessarily I put on a 100-pound backpacking back and now I'm doing the PCT. Load can be training load, so mileage, but also intensity and vert. So if you all of a sudden move to, near the AT, for example, and you're doing all this vert that you never did before, that counts as load, even if your mileage is the same. That can be an aspect in any musculoskeletal injury. So sometimes that shows up as plantar fasciitis. That is part of it. The mobility part, yes, with an asterisk. So big toe mobility is talked about a fair bit. Runners with bunions, this is hard because there's a physical restriction of the bone running into the other bone. So big toe extension, so that's when you're bringing your big toe up towards your face. It can help your foot roll through when you're on the back end of your stride and actually share the load throughout your foot. Versus if you don't have that, you're kind of just using the meaty part of your foot to do everything, and you're not actually getting that nice bend in your foot to follow through on your stride. So that is part of it. People go really way too hard on the mobility part, though. So
perfect for me.
This is in the stretching realm, right? I don't stretch that much. Maybe that's horrible. It hasn't hurt me yet. So maybe in 10 years, I'll listen back to this podcast and be like, damn it, I should have stretched. But
if any of my athletes are listening, I still want you to do mobility.
No, I'm not your coach. Listen to your coach. Right?
Do as I say, not as I do, Jeff.
Yes.
There are certain mobility things I still focus on for my feet, and my like dorsiflexion is important to me because of that. I live in a flat area, and going up vert will cause me to have fake PF concerns.
Yep. And like the one we'll go over and over again with all these injuries is hip internal rotation. So when you're thinking of internal versus external rotation, external rotation is kind of like you're sitting on a horse and you're a cowboy. Internal rotation is the knock knee position. If you don't have the ability to access internal rotation, that knock knee position, the back of your stride will be limited. So that's the two motions, your hip extension in the back of your stride and hip internal rotation, the knock knee, they go together. So if you don't have, usually it's more common that the rotation is limited. And if you don't have that, you got to compensate somewhere else. And it's usually in the low back. That's like the easiest place to get the back of your stride kind of arching back to access it. But internal rotation's everywhere. That is like, if runners had to focus on one thing for mobility, for injury prevention, it's hip internal rotation all day.
We have a couple more plantar fasciitis questions, but when you talk about focusing on hip mobility and internal external rotation, what are you talking about? Just so everybody can just kind of go, what would be an example of the exercises they would want to do? So if they stop listening after this, they've heard the most important thing they need to do.
They're going to go do it. Yep.
Yeah. What would that be?
There's a few that are kind of go-tos. One, some people call it a hurdler stretch. The back leg of a hurdler is internal rotation. They're really good at it. So if you hurdle, you're fine. That's one that's a go-to. The other is 90-90. Those are often just conflated as the same thing. I use them interchangeably. And then big ones it's called hip, pails, rails, and cars. That's spelled exactly like you would think it is. It comes from a whole school of thought about mobility. But those are a series of they're not resisted. It's just moving the leg actively in the absolute end range of your available motion. So how to pair that, you do the stretches, so hurdler or 90-90. Do that, you hold it for a long time. You don't just sit in it for 2 seconds and get out. And then you add the active part, and the active part is what will make that flexibility stick longer term.
So listeners, hurdle, 90-90. And I'll say it again because it's not a familiar term. Pails, rails, and cars, right?
Yep.
Yeah. Pails, rails, cars. Actually, I had a online coach years and years ago taught me some of that too as well.
Yeah.
So check it out. PF. Steve, let's go back to plantar fasciitis.
Absolutely. And I know you mentioned it before too. I don't know if it was before I think it was when we started. But is there a go, no go with it in terms of like, when do we stop running? When do we not? I know there's different trains of thoughts, but what I have heard is it's actually counterproductive if you stop when you have PF a little bit, because then you have to kind of build that, I don't want to say build that plantar fascia or that fascia back up, but what are your thoughts on that?
Yeah, this is similar where the two categories mean different things. So true plantar fasciitis, inflammation in the fascia or tears, that's a pretty much hard stop for the first couple weeks. But that's not a decision to make. That's oh my God, I can't walk. So for coaches, right, it's not even a decision. The athlete will know, hey, I can't run. Even the most, hardened ultra runner will just not be able to run. That's pretty much a hard stop. The exception is if imaging shows little tiny micro tears, imaging meaning like MRI in this case, sometimes ultrasound, then it's okay to run through. And you're right that the load actually will help. Now for the fake nerve-mediated plantar fasciitis, run through it 100%. The nerve stuff is like irritation rather than damage. And in that case, your hard stop, or at least relative stop, go to cross training, is if you're limping hard enough that your running buddies are like, hey, what the hell's wrong with you? That's usually the stop. Other than that, you should train through it.
I had fake PF, folks, because I ran through mine. I was miserable. It's interesting because the people, and I'm not going to judge anybody I've worked with before, and they're probably going to listen to this think I'm judging them, but maybe I am. No, I'm not. Is that it does hurt, like, and how they determine like if they are fragile enough to endure if they've got fake or not is really a hard question because even though we're all ultra runners, right? Pain tolerance is pain tolerance, and some people can endure more than others when it comes to that type of pain. And so how do they get it officially diagnosed as real or fake? I mean, because if I go to my PT or somebody or to a chiropractor or even my doctor and say, I need to know if I have real or fake PT.
And they're not going to.
Yeah, excuse me. They're like, what are you talking about? Dr. Mandy told me about this.
Yeah. I heard this on a podcast.
Like a secret club.
Right.
Yeah.
And they're like, fake PF.
Right. So the fake, the medical terminology the most common diagnosis for the fake nerve-mediated is a radiculitis or a radiculopathy. So if you go to a doctor and you're like, do I have plantar fasciitis or radiculopathy? They're going to know what you're talking about. If you say fake PF, they're going to call me.
They're going to say, you're ridiculous with your radiculopathy.
Yeah. That's what we used to call it in school. But differentiating between the two, apart from just symptoms, imaging, so MRI, ultrasound, but it needs to be a very significant finding for the true plantar fasciitis.
Okay.
If you image a lot of runners' feet, they will show changes in the plantar fascia. There's a cool study on Olympians looking for stress fractures actually in the same way, and they found like 80% of the men's 10K field on some Olympic year had stress bone injuries, and they didn't even most of them didn't even know. They didn't feel anything.
Yeah.
So imaging can help. It needs to be significant. So the buzzwords there are edema, which means swelling, but it needs to be moderate. And then tearing or avulsion are the other two like buzzwords there. For the fake plantar fasciitis, the
Radiculopathy.
Yep, radiculopathy, radiculitis, interchangeable. That you need to go to somebody who, one, knows what that is. So they need to have some knowledge of neurodynamics, which sounds very woo-woo, but it's basically just the study of how do nerves work from a movement perspective. Like how do they stretch? How do they relax? Why do they send pain signals where they do? If you have knowledge there, there's tests to do, and that's orthopedic testing. So moving your legs around. Either one should have orthopedic testing. You really can't diagnose only off an image. It's a fallacy that people who stick it in ChatGPT will find. But yeah, so orthopedic testing for both with maybe imaging for true plantar fasciitis.
I think that's super helpful because, I mean, as a runner and, Steve, I don't think you've never had PF or anything, no, but for those that had it, you said 50% of the people come in that have had this, it is terrifying. It is one of those things you're like, I don't know what's wrong with my feet. I don't know if I'm gonna be able to run again. I don't know if I need to stop running. And to hear that there's a higher percentage of us that are going to have this radiculitis, radiculopathy, fake PF, whatever we want to call it here, it's actually encouraging because you can actually go to a doctor and you can go to a specialist to find out which one do I have, and now I have a better course of action. Because if it is the real PF and there is a tear and you're saying we should take the time off, it is a no-go at that point because the pain is going to be so high. But again, threshold pain is subjective. If we're unsure, then we should at least go get that confirmation, because if we don't have the real PF, we're just whining.
Yep. Grow pair. Yeah.
That's right. I didn't say that. But I believe that. So that's just a fact. So fantastic. Any ways to prevent it?
Like I said, the hip internal rotation, big toe mobility helps, and load management. The other part that is, I won't go super into this. I could talk about this for hours, but for true plantar fasciitis, I don't know, are you all familiar with REDS or relative energy deficiency? So for those who don't know, basically a mismatch of calories in, calories out, and your body starts shutting down what it deems as non-essential processes. A lot of which are, hey, can you heal the soft tissues that I just tore down by doing training? So if you have a problem there, you're under fueling either intentionally or not, then that can predispose you to soft tissue injury, this included.
Yeah, you see that a lot in athletes who are trying to not only exercise for endurance type sports, but to diet on top of it.
Yes. Yeah.
So it's not a win-win.
No, it is a trade-off.
Right. That drastic weight loss that you're experiencing is not always a win-win here. It could have long-term effects on your training. So we have spent a lot of time on the first one.
Yes,
but I'm
okay
going to
make it through.
We may not make it through all of them, so I may have lied to everybody when I said there's 5, but we're going to go to number 2, unless there's anything else from PF we want to talk about.
No, I think I'm good.
Don't think so.
There's, again, if you want more information,
plenty more to talk about on it, but we should probably move on.
The book on it. But we will try to get through some of these a little bit more. Another very common one, IT band syndrome.
Yeah, I've also had this. I've collected the gauntlet of.
Well, this is one I
You've also
had,
had shin
Jeff.
splints.
I
have not had IT band. I have not had this IT band, but
that's great.
What is it and what causes it?
Yeah, so the IT band is also mostly a structure made up of fascia, so that long, flat band of not very stretchy tissue. And it starts from the side of your hip, attaches to the muscle called the tensor fasciolata, or the tensor enchilada if you are in grad school and trying to learn it. TFL up there all the way down, and it inserts itself into the bone right by your knee. So most runners who are experiencing IT band syndrome, they will have the pain at the outside of their knee. And IT band syndrome classically is friction between right about where it attaches down there and the IT band that lies over the bony structures in the knee. So it'll feel like, you're bending and straightening your knee, and it will be painful on the outside. It is typically not painful in that full line up the side of your leg. That, again, broken record here, look more at radiculopathy, radiculitis. But for true, actual IT band syndrome, it is a friction syndrome, and you'll find it called that often.
Steve, I've never had it. Did it hurt?
Yeah, I mean, it got to the point where it would take a little bit to warm up, but once I got going, it was fine. And maybe I had radiculopathy. I don't know. I could have been that.
Questioning everything.
Yeah. But then it would be,
We're just whiners.
yeah, it would be like where if I stopped and then try to start again, it would be like another quarter mile before it got moving, and then it was fine again.
Yeah.
Like,
There's a warm up effect.
Running, it was fine. And then like if I was walking, people would be like, that guy, there's no way that guy ever ran. But once it warmed up, it was fine.
Yeah. It's super common. Traffic lights are IT band's best friend in that sense. But the problem comes if you don't do anything about it, and it is that actual friction syndrome. Your body will put down scar tissue because it's trying to protect the fascia. And then it's easier to rub, and then it puts down more scar tissue, which is easier to rub, and you get in this really fun cycle.
So what do you do about it?
You treat it early. You don't wait. Yeah, I know everyone's railing against
all right,
that.
so let's start there then. So we're going to talk about what we do to treat it. But so if we don't treat it early, what is that one of the biggest mistakes we make as runners? We don't start to treat it early. Like, what are the mistakes we make when this begins to flare up then?
Yeah, not treating it early. This is also one of the more common ones where your body compensates more. Your knees are like, you can't escape using your knees. So if your knee hurts, everything's got to go somewhere else. If your pinky toe hurts, whatever, right? But yeah, not treating it early. That scar tissue effect can happen. I will say it's fairly rare, but it can happen. The bigger thing is you're going to injure yourself elsewhere, or it's going to flare up to the point where, like in the morning, even without like stepping on your leg, just bending and straightening your knee will hurt, or downstairs, or like picking up your kid or whatever you're doing, it'll just hurt all the time.
So what do we do?
Yeah, treat it early. You stop rolling your IT band.
That's the biggest one. Yeah, I hear a lot of people.
Okay, everybody pause for a minute. We're going to let the doctor say that one more time. You're saying we do or do not pull out that foam roller?
Do not put it in the corner. Let it collect dust.
Why though? We were told it puts pressure and applies pressure to those pain points. Tell us why again.
Yes, fascia does not stretch much. So if you're just rolling something that doesn't stretch and it hurts to roll it, all you're doing is hurting it while you're rolling it. It's not going to damage it, but why make it more sensitive when it's not going to help?
I'm going to just say it, Steve. I have oh my God. So I have been told that, how am I going to word this? I don't care. I've been told that you can just roll it, and that when things like that hurt, it's supposed to hurt. And so you just keep rolling it and it'll start to feel better. I'm like, no, you're just going numb.
Yeah.
So you just get used to it.
Yeah.
I was like, it's not getting better. Like, but you're supposed to roll. I'm like, you're not supposed to roll it. Because as you described it, for clarity wise, the reason you described it, you said the tendon is rubbing across the bone. So when we're applying pressure on it, we're just taking this inflamed tendon and we're just applying more pressure on top of that bone. And as opposed to just flexing our leg as we're moving it, we're just putting a foam roller on top of the same place where it hurts, and we're not even moving it now.
Right.
Like, this is just choosing to be.
Yeah, you're just prolonging it. And just small clarification too. So tendons and fascia are different structures. The fascia is really stiff. Tendons stretch. So you can technically kind of loosen up a tendon if you roll it ish. Fascia, you really can't. Like, the only way to loosen fascia is to get a surgical knife and go in there. You just won't do it. It's like putting a rolling pin on a steak. Like, it's just
we don't do that.
Yeah. So stop rolling your IT band.
Another thing too, I've heard that because the fascia, it's pretty much everywhere, right? It like lines the outside of your muscles.
Yeah.
When you are dehydrated, it kind of gums up a little bit. So you want to also make sure you're hydrated enough to be able to have that muscle slide back and forth across that fascia.
I've heard that. I don't know if there's any truth to it.
Okay.
I think the dehydration effect is small enough that it wouldn't make a feelable difference.
Got it.
That'd be my guess,
Okay.
but I'm not sure.
And is there anything you can do strength training wise or like to help out with that? Because I know as soon as I started doing like banded crab walks and like lateral movements, that's kind of what helped out.
Yeah. So the deficits in people with IT band syndrome most commonly is lateral stability or frontal plane stability, but moreover hinge. So that's your deadlift. So quad dominant athletes, which most ultra runners are, and that's fine to a degree. you have a knee problem, quad dominance is also known as knee dominance. So you are using the front of your leg more to do the task. And again, that's fine usually, but you do need hinge strength so that you're not just doing that all the time. It helps offload the IT band. So get deadlifting.
You're pulling your leg through instead of pushing it through, like off of the back part of your gait.
Right. And like for gait too, there's always co-contraction in the front of your leg and the back of your leg. They need to work together. But it's more when you're under more load. So the classic is downhill. You need to be able to do both. Uphill, it's pretty much just going to be quad dominant. Downhill, and this is why IT band syndrome hurts more downhill usually. You need both strength, like posterior chain hinge strength and the quad dominant, knee dominant strength.
Deadlifts, you said?
Deadlifts.
Two more of the top exercises we should be doing to prevent IT band syndrome.
Yeah, deadlifts is number 1 through 10, but but if we're going a 2 and 3 in there, some sort of lateral stability exercise. So that doesn't necessarily need to be lateral lunges or side lunges. That's good to build up after you are asymptomatic. If you do it while you're symptomatic, that's going to be tough. But after you're out of the woods, start doing that. And then pretty much any single leg thing that is loaded. So single leg RDL is popular, kickstand RDL, anything of that flavor. There's a ton of PT exercises that you can look up, just single leg stability, but it needs to be loaded. So it needs to have weight on it.
I want to pause on that because I do want to talk about it being loaded. So because there's a lot of different camps on this about how much weight they need. And I'll be transparent before you tell me I'm wrong. So I'm of the camp that most runners aren't doing anything at all. And what I want them to do is to do what they feel is accomplishable to start. And so I tend to prescribe more body weight and lightweight type activities just so they can do them and they get into the routine, do them. And I encourage them as you begin to build more balance, stability, doing some of these body weight type things or low weight things, you can increase weight. But you've emphasized load a few times. And so when we talk about single leg deadlifts or single RDLs, which is a very common one that coaches give out to their runners, how much load? Are we talking about any load or heavy? Like, are we talking about Olympic weight lifting now?
Yeah, it should be enough load that you're sore the next day. That's a fair rule of thumb. And it should be, if you're really actually like you've done weight training before and you're literate in it, I usually start going once you've learned the form and you've done it for a few weeks. I use RPE often, so rate of perceived exertion. I get up to RPE 8 usually in the last set. So classic rep and set range, say for a deadlift, is 5 sets, 5 reps. And then you should have 2-ish reps left in the tank in your last set. So this is heavy. You should be sore.
Yeah, I'm gonna just, again, before my athletes all start yelling at me about my strength training, I'm gonna say it this way. They are more than welcome to do that. Yep. If they have bad form, they will be injured.
Yeah.
Yes. Well, probably. There's an allowable range, but yes.
Right. There. If they have bad form, there is a higher potential of them being injured. And so I would encourage them. They can start doing them. Do body weight. Get used to the form. Make sure your form is on point. Add that weight in is fine. But that's my only caveat to that.
Yeah. You gotta get someone to teach you the form.
Right.
You just can't avoid it. You just have to do it. Yep.
At that gym. Go or no go?
Yeah. An IT band is basically a go. There's not much no go on it. The same thing of, your buddy tells you you're running weird and it's really obvious. Maybe step back. But because this responds so well to strength training, it's a go. The one modification that is helpful, particularly for people who are running more technical trails, is to use poles. Always have a rubber tip on the poles in case you fall. You do not want to pole yourself, which has happened to athletes before. But technical trails with poles, since the lateral stability part is the deficit and the hinge, it can really help as you're training through it.
Interesting. It's an extra good point. Patellar tendinopathy.
I love it. Yes.
Also known as runner's knee. So this is our IT band syndrome's friend to the inside a little bit more. It's on a different part of the knee. What is patellar tendinopathy? Again, classic runner's knee.
Yeah. So starting with tendinopathy. Some people have seen it as tendinitis or tendinosis or tenosynovitis. Tendinopathy just means tendon problem. And it's now most practitioners will use tendinopathy because it mostly doesn't matter what's happening in there. We know it's a tendon problem and it responds to the same things. For patellar tendinopathy, it's the tendon that goes right below your kneecap and inserts at the top of your shin bone. If you played sports as a child, you might have a bump right where it attaches in the shin bone. I have a huge one. It's like gnarly. I can't like kneel on hard surfaces. A whole different thing that's called Osgood-Schlatter, but that's for young kids. But it is the tendon that runs between those two places. And it's actually runner's knee is more commonly the cartilage under the kneecap, but runner's knee and jumper's knee are conflated a lot. Technically, patellar tendinopathy is jumper's knee. If you look it up, runner's knee, it's going to tell you either or. So
yeah, I think somebody gave me that. I don't know where I came up with it.
Yeah. No, people use it interchangeably.
So patellar tendinopathy is not runner's knee.
Google will tell you that half the time. At the end of the day, problem. Right. So jumper's knee and runner's knee are not diagnoses. It's colloquialisms. So, you say, I have pain below my kneecap. Great. I got you. We know what we're doing.
Mandy, you were talking to people who use Google MD.
Yeah.
I know. Yes.
And ChatGPT.
I mean, everybody listening is like, I don't know what she's talking about. This says runner's knee. It's Google MD. I think she's wrong. She needs to go back to school. So we go
runner's knee / jumper's knee / patellar tendon. Just if you got pain in that tendon, that's what we're talking about.
So is it caused by overtraining or bad mechanics?
Bad mechanics more. I usually put overtraining as an under recovery more than an overtraining. People run, the top ultra runners are running upwards of 150 miles a week.
Yep.
A lot of them. Not all of them, interestingly. I have a few pro ultra runners who are, pumping it out on like 60, which is cool. Right. They're fine most of the time. So clearly there's not a hard stop for everyone. Under recovery, not the like, I'm going to go do cryotherapy and like all the little things. That's the 1%ers where you just get a little bit of extra maybe. Under recovery is more like, I'm not sleeping enough. I'm not eating enough. Eating is number one on the priority list. I have a ton of stress at work and therefore like I just don't have enough left in the tank to do this 30-mile long run. So overtraining, under recovering can be an aspect, but it's a factor, not a cause usually. The cause is biomechanics. So how you're moving, where you're loading again. So where your body absorbs shock and where it uses to perform the task. So what muscles are you actually using to do the task of running uphill or downhill or flat?
Does it happen more if you're, let's say, overstriding, where your foot is landing out in front of you? Because most of the time you want to stay by like your center of mass, right?
Yeah. I'm going to preface this is my opinion, and I don't know if it is empirically true or not.
So Dr. Mandy says it's true, so it's fine.
Yeah,
Google MD is going to say it. I'm going to verify.
Right. I'm going to get some email from another like practitioner like, you suck. I don't truly believe in overstriding unless someone is trying to change their form. So I am not a big proponent of you need to think about this when you are running in terms of form changes. One, because people forget like half a mile in. You're taking so many thousands of steps that you're just not going to remember. And two, your body's default of form may be better than trying to change it, is almost always. If there is a problem biomechanic-wise, you need to do something challenging enough to change it without you thinking about it. So again, broken record.
That's good.
Strength work.
It's very nuanced, though. I think that's a very nuanced.
It's truth. A whole conversation. Yeah. It
is, because I agree with a lot of what you're saying. I disagree also with a lot of what you're saying.
Yeah.
I see it both ways because is it a problem? I do believe people have a natural running form. That's where I agree with you 100% because I think we get into trouble when we try to change everything so quickly.
Yes.
So I agree 100%. I also think that some people's natural running form does need a little bit of tweaking. And that they tend to overstride because overstriding causes breaking. And so what I tell runners is that if you don't have any injuries, then don't worry about anything.
Yes.
Keep running like the giraffe that you are and don't worry about it.
Yep.
Don't worry about if you're under or overstriding, it doesn't matter.
Yeah.
If, however, you are injury prone, particularly with knee issues, I say, let's see if we can't tweak something. And so we pick like one area, and that one area would be something like cadence. And if I can bring them their cadence down, and to Steve's point, like getting their hips back over center mass and trying to line them a little bit better is the same concept. But if they're overstriding or they're having knee problems, I just try to bring that stride in a little bit shorter or pick up their cadence. I don't have a cadence target.
Yeah.
So if their cadence is 150 and everyone's like, they should be 190, I don't care. I'm no, let's make your cadence 153.
Yeah.
Like I just want it to be increased a little bit. And so we just work on that for months.
Yeah.
And so it just takes a long time because to your other point you made, I agree with it, is that you can't naturally just do it.
Right.
Like as you get tired, you're going to fall back into old habits. So you have to train new habits. And that takes months and months and months of training. So I agree with a lot of what you said. I also disagree with some of it.
But it's controversial for sure.
But it's not wrong. Like none of it is. There's so much to it. That's right. There's so many pieces to it that there's a lot of truth that kind of slides together that there is no right answer. There are lots of pieces of a puzzle.
Yes.
That's how I see it. So maybe we made it too complicated by saying we think it's overstriding, but
yeah, I mean, form can be a factor in patellar tendinopathy. Changing it is where it's controversial, but it can be a factor. The change, like I said before, thinking about it usually doesn't work. What the middle ground of just doing a ton of strength and changing it, so you're not actually, like consciously changing anything, is if you want to produce short-term change, like say they are in pain, you're a coach, you want to do something form-wise, you have to give them an external cue. So it's not necessarily like hips go over knees. It might be like if you're talking about cadence, like hear the rhythm of it. It needs to be something that's not internal, not in your body. It needs to be a task.
You listen to music. You find you can do them on. You can find playlists that are certain cadences.
BPM. External cues are processed in a different part of the brain, and it produces motor learning that sticks better.
That's fantastic.
Versus like saying like, oh yeah, pick up your heels when you're in the back of your stride. That's harder to learn. Yeah.
Agreed. It's really hard to do that. Go ahead, Steve. Sorry.
I was going to say, I also heard that, I forget which famous USA track and field coach said it, but he said if you want to fix people's form, have them do hills or sprint work, because that naturally puts your body into the correct running position.
Yes. So on the coaching side of things, like I said, I coach high school cross country, and they do some road and trail stuff in the off season, which is fun. But I have them, the new kids, the returning kids, the kids about to go NCAA, all of them do hills at some point. Even if our season is mostly flat races, in the beginning of summer, we're doing hills because your form just from a technique standpoint gets better. And even better than that, your efficiency for performance standpoints gets better. I know what coach you're talking about. I can't think of their name either. But yes, I'm fully
ridiculously famous coach that neither of us can remember.
They must be better than us, that's for sure. Let's just go with it.
They know, they're more known than we are. That's
there you go.
Sure.
All right, so top exercises to solve this riddle.
Yes.
Let's do it this way. Top exercises to prevent this riddle.
Yes. Prevent offloading the knee. So it actually looks fairly similar to IT band exercises. We're getting hip dominant hinge work is important.
Okay.
Runners doing more technical stuff, getting some little amount of plyometric work will help. So more dynamic, like A skips, B skips, stuff like that. But I find that it's just easier to be like, hey, on a Wednesday, instead of doing your long fire road run, go do a shorter technical route. And then you can get exposure to like plyometrics because they're jumping down rocks. Right? But hinging, huge. When you actually have it, it gets really, you got to walk a really fine line with this one, specifically with patellar tendinopathy. So isometrics are what we hear about all the time in tendon injuries. It's basically you're doing a muscle contraction, but you're not moving at all. For the classic one is Achilles tendinitis, which we'll talk about. But like you're stepping off the edge of a stair and you're holding a weight or a backpack and you're just holding your heel in the air without actually doing a calf raise. That's an isometric. So those are really helpful for patellar tendinopathy if you load it right. And it gets super touchy. And that's where it's like, it's a throwaway comment, but you need someone to coach you through that. It's really fine line there, but it helps. It does wonders.
Would something like a wall sit help with the patellar tendinopathy?
Yeah. So I'll spare you getting the nitty gritty, but wall sits are a quad isometric. So if you load it right, that can help. If you decrease or increase the angle of the knee, so if you're in a deeper wall sit or a more shallow one, that biases different muscles in your quad. So your quad is made up of 4 muscles. That's why it's called a quad. And depending on where you're at in terms of angle, you will bias different quad muscles, which pull differently on the kneecap. Some of them kind of pull it more to the side. Some are just up. Some are to the other side. So you can kind of play with that of how deep or how shallow. Usually you have to do at least one that's in fairly neutral, so like 90 degrees, and one that's either deeper or more shallow. The question is which one, deeper or more shallow. But yeah, wall sits can help. You just got to dose it right.
Sounds brutal.
It's brutal. Jake Tura is a great resource for this. He actually has a podcast. It's called The Jacked Athlete. Great name. He's not a runner. He's a basketball player, but he has basically dedicated his career to patellar tendinopathy, called jumper's knee for his purposes. But he has a ton of great resources for this.
He has an entire podcast on this one issue.
Pretty much. I mean, he starts touching into other stuff, but it's pretty much this. He does research. He does post about it, a lot of content about it. He has books. He has programs. He is the patellar tendinopathy guy.
I mean, that's a lot on one topic.
It's a lot. It gets really, really molecule size granular.
I want to know if it's a go or no go.
It's a go. Yeah.
I love all these answers being go so far. All my listeners are like, yes, Steve, they're thrilled with us right now.
Yep.
Yeah.
You're not telling me I can't run.
Yeah. So no-go rule of thumb, obviously, if it's a bone injury, stop. There's a guy I know trying to train for a long race that has a bone injury, and I'm not his doctor. I'm his friend. Bone injury, absolute no-go. If you have huge amount of swelling and pain with it, usually a no-go. If there's a ton of bruising and you can't weight bear on it, usually a no-go. Exception is ankle sprains, which actually the sooner you get back into it, the better.
Wow.
Or if it's like an obvious, I heard something tear and now I'm scared, then go get imaging right now.
So you hear that, Steve, all of our people that we know and love, we'll just say people, not even that work with us, people on social media who, I'll say, I DNF, so I can say this, that have DNF because they had a hurt that probably wasn't a reason to DNF.
Nope.
Probably not.
Just go.
That sucked, man.
Yep.
I'm going to cut this part out. Just kidding. All right, let's go to the next one. Unless, Steve, do you have anything else on runner's knee, also known as jumper's knee, or whatever? I said it all wrong. Nothing else.
That's why we had to bring a subject matter expert on.
I mean, 'cause we're just making crap up today anyhow. So
That's what it looks like.
we're touching it all. Low back pain.
Yeah.
This is probably problematic in runners after or during a really long training run or towards the end of a race. And I don't want to complicate the conversation. Well, I'm not going to go any further. We'll just say low back pain. I don't want to complicate it. Low back pain. Is it an issue with the back or something else?
Usually the back. That's one that if it's in your back, it's in your back. If you're thinking about, like, say for the other stuff we talked about where there's like a fake version of it, talking about like a nerve version, the nerves all come from the back. So if it's your back, it's your back. The only exception is if it's a weird like organ thing. Like if your heart starts hurting and your shoulder blades start hurting, don't listen to a word I'm about to say. Go to the ER. Just don't mess with it. But a back's a back, pretty through and through. The difference is does it radiate? Is it also in concurrence with a different area? So not necessarily a sciatica, like it doesn't have to hurt all the way down your hamstring. It can be like, I have a little back pain and my foot hurts, kind of in a plantar fasciitis way. But there's radicular pain. There is just local low back pain. And the two main diagnostic spots of that is a disc problem. There's different categories: disc bulge, herniation, extrusion, all that. As long as it hasn't exploded, you can just call it a disc problem.
Mm-hmm.
It's not going to change what you do. It's just a problem with the disc. And then the disc is in between the two vertebrae too. It's kind of like the shock absorber. So problem with disc is more commonly local low back pain or pain that radiates to or above the knee. If you're getting below the knee or local, kind of any flavor of low back pain, whether it is radicular or not, that's more commonly a nerve root problem. And that can either be in the nerve root itself, where the nerve is swollen. They can swell. They just don't blow up in the same sense of like a torn ACL. It can be a nerve root, little irritation, swelling, or it can be the hole where the nerve root comes out of. And that's more common in older runners. As we age, the hole where that nerve root comes out, it sits in between the two vertebrae. And as we age, that hole gets smaller, just naturally. And more, it's called age-related changes instead of degenerative. Because nothing's degenerating. You're putting on more bone. That's A-generating, right? That's more, not D. So that is more common in older ultra runners, but I see it all the time in younger ones too. So those are the two main things.
So is it an acute injury then? In other words, is it happening because at the end of my race, I've inflamed the disc or inflamed this nerve, and then I'm going to take my couple days off my race and it's going to resolve itself? Is this really just an acute type thing?
This is actually more commonly chronic.
Interesting.
Acute low back pain, unfortunately, almost always turns chronic unless you attack it early. And even when you do, I don't lie to my patients. I say it will come back at some point.
Mm-hmm.
The goal is not to wave a magic wand and it go away completely, because that's not realistic. The goal is have it be 10 years from now for a 1 out of 10 on the pain scale, and it's going to go away in a couple days, rather than you're going to throw out your back, say, 2 months after you see me, right?
Mm-hmm.
But most commonly it's chronic. The only exception to this is throwing out your back. And that's almost always a disc problem. So a small disc bulge or herniation, that would be the acute part of it.
So why is it showing up at the end of the races?
That's a great question.
You know what I mean? Like, why is it showing up then? That's why I say, is it acute?
Yeah. Acute more commonly is like you've damaged something and it shows up and it's aggressive. It can also just mean the time scale. So like, I didn't have this before and now I have it. Like I'm 80 miles in and now my back hurts. That is more from a biomechanics standpoint. So again, hip internal rotation. Ultra runners in particular, with the back end of your stride, if there's something going on weird there, the place you're going to cheat is your low back. So then you're putting more stress and more load into your low back. And after a while, it gets tired, it gets overstressed, it kind of locks up. I usually, like, if I'm actively dealing with low back stuff myself, it's really common, like fast downhill end of the race is when I'll feel it. And then after the race, it'll cramp up really fun and I'll just lay on the ground. But yeah, it is a biomechanics problem, no matter which way you slice it.
Is there anything you do? Is it like having a better, stronger core or stuff like that that's able to help push that off a little bit to further in the race, or not at all?
Yeah, I'll start with the converse of that. The thing that people look up and they see a lot is strengthen your low back, which is not helpful as always.
Perfect. I don't do it, so it's great.
Great. Yeah, don't need to hammer like Superman in the gym, all that. The reason being, low back is made up of smaller little muscles that stabilize. They're more postural muscles. I'm not even going to get into all that, but they're postural muscles, so they're not designed to do movement all that much. They're just designed to keep your spine in the position it's in, plus or minus. Bigger, meatier muscles are the ones that are supposed to take the load. So your hip muscles, core muscles. So you will see online, like, do a ton of core work and do a lot of like clamshells and hip hinges and stuff like that. There's a lot of truth to that. It is cliche, but it's true. Just depends on the diagnosis for which way you do it. This is helpful for kind of the public to know, but the way that we assess what's going to be more likely to be helpful or not is to find what's called a directional preference. So really easy. It's like, okay, if my back hurts when I'm touching my toes, you are a flexion touch toe intolerant low back. if my back hurts when I'm doing a back bend, then you are an extension intolerant low back. So a watered down version that can help simple cases is, say it hurts to touch your toes. Okay, you need to do things that are anti-flexion. So you need to do stuff that's strengthening posterior chain. So that's like hamstrings, hips, glutes. If you are an extension intolerant back and bending backwards hurts, that's a lot of front of the core work. It's actually a little bit of breath work too, to uncompress the spine. And then getting into multi-directional movement is usually helpful too. But yeah, it gets nitty gritty.
Yeah. So as you were going through that, I kept thinking, all right, and it's something I probably would reiterate at the very end, but I'm just going to say it now at this point. This particular one, because you described it as chronic, even though I keep yelling at you saying, no, it's acute because of when it pops up right at the end. Mm-hmm. But it's a chronic condition that is expressing itself acutely at the end of the race. How about that? Yes. And so what I'm hearing, because it's a chronic thing and it's not just going to go away on its own, if you will, mm-hmm. then what I think people who experience that in a race, as opposed to saying, well, the race is over and a couple of days later, my low back pain's resolved, I don't need to worry about it. Mm-hmm. It may still be a good idea for you to call up somebody like the Performance Place people or go to some local individuals that can give you a professional assessment mm-hmm. to figure out the directional problem of mm-hmm. your back, if you will, like they're mm-hmm. the right way to go, so that they can then be informed of which exercise to do, as opposed to, like Jeff would do, go to Google MD or go find a YouTube video and just kind of do some Supermans and say, well, everything seems to be getting stronger. I did this, it seems to be getting great.
Yep.
So, if anything that's coming out of this, I think it's very helpful to hear like something like that does seem to be acute is one of those ones that is not going to go away. You're not just going to magically solve it without getting some more information, getting it properly assessed and knowing really what you're dealing with. So
yeah. It's also top of the flow chart for a lot of other injuries. Mm-hmm. So like when we were talking about that, the fake plantar fasciitis, fake, mm-hmm. all that, I am going with the patient and I'm hearing their history of previous injuries. I've had it over and over where it's like, I have plantar fasciitis now. It feels like plantar fasciitis. I used to be a CrossFit athlete. I blew out my back 10 years ago, but whatever, my back doesn't hurt. That is often the top of the flow chart.
Mandy, it's because they did those loaded deadlifts, right?
They did a Murphy. Yeah, we did 200 deadlifts in one day, and I can't walk now. Yeah. So if you're thinking about priority injuries of like, can I ignore it, or do I actually go see somebody? Back pain, low back problems is top of the priority list. You actually have to address that one.
Mm-hmm. It's interesting. And again, your other thing you've said, the other commonality is a lot of your hip. We have all weak hips too. Mm-hmm. So anything else on back pain, Steve? I'm looking through my notes. I got so distracted on this acute thing that I don't know if I hit everything I wanted to say on this. And I apologize for that.
No, I think it's good. I mean, that one, because it's just going to spread to other areas if you don't take care of it.
Yep. And then you're going to be confused because it'll feel like a moving target. So mm-hmm. I would deal with it.
Well, we're working our way back down to the feet.
Yep.
So we started with the plantar fasciitis at the bottom of the foot, and then you said sometimes we get this feeling that it's shooting up the back of our Achilles. I never had that, even though I had the fake one apparently. Achilles tendinitis, though. What's going on here, and how do I know? Okay, it's not ruptured, because I know when it ruptures, it's a whole nother ballgame. So if anybody's torn the Achilles, we're not talking about a torn Achilles. You will not be running with a torn Achilles.
Nope. You will fall down and it'll feel like you got shot. So you'll know.
Right. So we're not talking about a torn Achilles. We're talking about the inflammation of the Achilles tendon.
Yes.
Let's talk about that. What's going on here?
Yeah. So Achilles tendon runs from the bottom of your calf to the back of your heel. If you have pain anywhere other than that, it is not your Achilles tendon. It's the fake version. Spoiler. Achilles tendinitis. That tendon is fairly long compared to other tendons in the body. So you'll actually see a fair amount of variance in different runners. You see the ones that have like really tiny calf muscles really high up. Their Achilles tendon is super long because the end of the muscle is where the tendon starts. Mm-hmm. Versus people who have like really thick calves at the bottom, short Achilles tendon. It's not necessarily that one is better or worse. Obviously, you can't change it, so it doesn't matter. But in terms of like area of pain, it can vary some, but it is never going to go below the bump in the back of the heel. Most commonly, people have pain just above the bump in the back of the heel with or without swelling. So the giveaway for a true like Achilles tendinitis, more than other areas, is swelling, because you can actually see it, and not the feeling of swelling. It has to be visible. You have to see it puffy. And usually that's, again, right above the bone where it attaches in the heel. But it hurts. It hurts like a bitch. It's one of the more common ones that I see. And if you go to anyone who does rehab, it's like a broken record. I'm sure at Fleet Feet, it's like plantar fasciitis, Achilles tendinopathy. Yep. That's like 90%. But yeah, so that's the main kind of like where you're going to feel it.
I got two areas I want to talk about this, Steve. I don't know if you want to go with any of yours first, though.
I was just going to say, like, what is it? I mean, we talk about what it is, but what causes it?
Yeah, overloaded the tendon. So there is the cliche too much too soon. But like we were talking about earlier, there's too many factors for too much. So the too much can come from mileage. That's like the classic thing, right? It can come from intensity that puts more load on the Achilles than other activities, since you're just pushing off faster, and your energy return needs to be more snappy. It can be you just started doing yoga and now you're stretching a ton and your tendon's not used to that. It can be more vert. It can be I was running in I didn't know I wasn't supposed to run in carbon plated shoes all the time, and now I'm running in ultras. Like, that is a lot of stress on the Achilles. So it is technically a too much too soon, but it is, if you blanket all of that with load, it's a load management problem.
Yeah, I want to talk about shoes in a minute, and maybe even circle back to plantar fasciitis and Achilles tendinitis on that topic. But for all these, we did this no-go type things. But there are some of these, like this Achilles one, that personally I've had tenderness there. I haven't had like a real issue where it was extreme or anything. But it's one of the areas that I kind of joked about, that we're not talking about a torn Achilles, right? However, this is one that does strike fear in me.
Yes.
And the reason it strikes fear is because I've watched enough TV shows and basketball sporting events where people tear their Achilles and they're laying on the ground and it looks like their foot just wants to flop. I know it's not, but it's just my brain tells me that, right? Or it looks like their calf shot all the way up. Who knows? Like, there's just...
That is what happens if you rupture it.
Right. And so it is a fear that comes up when my Achilles, or somebody that I'm talking to, their back, their Achilles, whatever, tendon starts to feel a little sore, right? So they're like, is it going to tear? Am I risking a tear when it's sore? Ooh, right? It's a hard question to say, because how you answer this, like, am I going to sue Mandy? Right. Let's just say this real quick. Nobody has signed a waiver with Mandy, so this is not, you cannot sue her at this point.
Yeah, I got great malpractice insurance.
Right. But you understand the question, right?
Yes.
The fear, that's the fear.
The fear is warranted to a degree.
Okay.
So there is classically a sign for ruptures.
Oh,
and the
Lord,
longer it can be soreness. So this is if you're predisposed to rupture and you're doing something really intense really soon. So basketball is classic. You're jumping a ton. If you are under training that area and then you go do a ton of dunks, that's when it happens. But most commonly, people will feel a little something in there before. So it can be achiness. Now, it is rare. People really don't tear their Achilles as much as it seems like. The media for sure plays that up, because like, dude, look at this gross thing that happened. If you get really into like the weightlifting, like meathead side of social media, it's that, but in the bicep.
It's biceps. Yeah, biceps. Same thing.
Which is so gnarly. Just seeing it is so gross, but it's not that common. It's really not that common. And there is the warning sign of like, feels kind of tendinopathy-y, but there has to be other factors too. So like way overloading it. If you have relative energy deficiency in sport, there's an under recovery part of it. You might be 80 years old and starting to run for the first time and your tendons just don't stretch that much. You need more collagen, things like that. So it's not just my Achilles aches and now I'm going to tear it.
Okay.
It's a confluence of factors. So if it's just achy, but you're like otherwise good, Don't worry too much, but don't sue me for that. Don't put it in ink.
So is it a go? So is it a go or no go?
Definitely a go.
Definitely a go. That's
Yeah.
good to hear.
Achilles is actually, and this is like well understood more than the others. Achilles is something you have to load. You just have to work on it. Tendons respond really poorly to rest, except for one brand, but the rare brand. But it is something you have to load. So the classic, right? Do heel raises and calf raises and isometrics. Completely true for this. The tendon actually swells a little bit. You can see the swelling or not. So seeing the swelling is the hallmark of like, yep, that's Achilles tendinitis. But the tendon itself, it almost like, it'd be like if you put a dry sponge in a dish full of water, it'll absorb a lot. It's trying to protect itself and become more stretchy so that you don't keep over stretching it. So when you do things like isometrics, when you're contracting the muscle that attaches to that tendon, you're squishing the water out, which is what you want. It doesn't need to be there. It's just a reaction of, hey, this feels damaged. Can you like protect it a little bit? So you need to load it. If that stays there for a long time, it just causes deconditioning. And it's the same thing. It's like a much harder hole to come out of. That
makes sense. So the last topic on these injuries here, and I said I want to talk about shoes.
Yeah.
It is controversial. It is conspiracy theory.
You're going to get emails about what I'm about to say.
There is so much drama, baby mama drama that comes out of shoe discussions. And Steve and I, before the show, we're trying to figure out ways we can get into some of the drama that's going on in the ultra running community right now with other very experienced people. And I'm not going to say their names, but we were trying to figure out how to get our own drama. So we figured this may be one of those topics.
Yep.
I'll just do it this way. Why do ultras get a bad rap?
Because people jump into them when they're not used to them.
Okay.
Yeah.
I actually agree with that. I got my issues from ultras is what I would say. However, I have learned that that's not actually the reason. But let's talk about it. So shoe conspiracies. Why do ultras get a bad rap? Like you said, they are one of the ones that people jump into. They have a 0 millimeter drop.
Yep.
Most people are used to a much, most of them. That's right, because they have a new one, right?
Yeah, they did the 3 or the 4 now.
They have 2 models that have, or 4 models that have 4 millimeter drop to it.
Yeah. Which is good. What are those models, Steve? Because people may not know.
They're the Experience Flow and the Forward Via, and the Experience Wilds, their trail shoe.
And they have 4 millimeter drop, because actually I bought a pair of those to use to kick around in. So let's talk about it. What's your perspective on this whole shoe drama?
Yeah, I've heard about it a lot. One, I haven't experienced it. So this is from patients and clients that I've seen and just, hearing about it in the ultra world from people I run with. Ultras get a really bad rap. Hokas seem to be everybody's favorite golden child. And then everything in between is like, well, that's not a real trail shoe.
And that's not fair either.
I know. No, none of it's fair. So for ultras, starting with that, there's the classic, like, my Achilles blew up because I now running in ultras. It's just the same equation. It's just a load equation. It's the exact same thing as I did a ton of vert and I wasn't used to it. It's just a shoe. So it's an external implemented thing for that. If you are preparing for that and you really want to be in ultras, then you're going to be fine. But if you go from like a Pegasus or like a Zagama and then straight into the ultras, it's not going to work. You just need to titrate into it.
So pause there. What is the heel drop on the Zagama?
Probably like 9 or 10.
I think it's Nike standard is 10 usually. Same with the pegs, I think. At least it used to be.
So it's a pretty big drop. I think the glycerins, I used to wear the Brooks glycerin for years, and I was like a 12 or something.
Yep.
Yeah. And I went to an ultra.
Oh, wow. Immediately?
Yeah.
Well,
there you go.
And I'll say it this way, because the coach I was working with at that time, not the coach I am with now, but the coach I was working with at that time, ran in ultras and highly recommended me start running in ultras.
And there's like,
it's not his fault
to it, I guess.
It's not his fault. Yeah. It's definitely not his fault. But I was influenced to do that. And because of that experience, I was like, I hate ultras. However, I am trying to not hate ultras, but it is because, so the reason is not because of ultras. It's because of the significant change in heel drop. And so the reason people are experiencing these foot issues is because of that drastic change in the drop. That's what I have come to believe.
Yeah. Yeah.
Are we all on the same
And
page?
yeah, I will say too, the majority of people who hop right down to ultras don't have a problem. It's the people who have a problem are just louder about it. Like you don't hear every time that somebody changes a shoe. You hear if it's horrible.
That's
So,
exactly right.
yeah.
Because we love negativity, Mandy.
Yeah, you got to that gets clicks, man. So
That's exactly right.
yeah.
Yeah, I agree with that. Steve, what like in all your work at the shoe store, like that's what you see too, right?
Yeah, I mean, if I'm moving somebody to an ultra because either they requested it or they wanted something with like a wider toe box, I either step them down into the 4 millimeter, which has been a really great, or let them know, hey, rotate these in for a couple weeks.
Mhm.
Like start off with 2 days a week, 3 days a week, and then go into it that way. Don't just go out and run your marathon in a brand new pair of ultras after you've come from a glycerin that's 12 millimeter drop. So
It's me.
Yep.
I ended up I wear the Hoka Cliftons. I've been wearing them for probably about 5 years now. I haven't had any more problems with my feet, but they're a 5 millimeter drop. And I found the 5 to be good, which is why I tried the Flow, Steve, because you'd recommended about a year ago. I tried them. They're a 4, didn't have any issues with them. I just still prefer the Hoka, how it feels my foot. But for those looking at the Ultras, they have a huge benefit. Their toe box is fantastic. And it's important to kind of pay attention to your cramped toes versus a toe box. And so that is a strong suit for that shoe.
Yeah,
and
if you
then
like your toenails.
Yep. Topo also is a good alternative, and that's if they're a 5 millimeter drop.
I've never worn Topos. They're good too.
Yeah.
Yeah, I need to try that out. So for the Topo CEO that's listening to this podcast, not at all, but if he was, I'd love a pair.
Yeah,
Probably not going to get one.
I'm not. All right, so let's kind of start wrapping this up a little bit. I'd like to ask this question because I think I think I already know kind of what your answer is going to be. But if you could get every runner that's listening to this podcast to do just 3 things consistently, what would they be?
Strength train.
Okay.
100% with weights.
Okay.
Not looking at anyone in particular.
Hey, I don't feel guilty. I done told you, if you blow my back out, I'm suing you. Keep going.
Well, then you're going to give me money because I'm going to fix you. But yeah, strength training with weights must be loaded safely. Work on hip internal rotation. So most hip mobility routines will have something in there, but you have to make it active to make it mobility instead of just flexibility. And then other than that, just manage load. Don't worry so much about the mileage. Your coaches are going to know what to do. They're smart people. So it's all the other things. It's under recovering. You need to eat. You need to sleep. If you're doing that, you're 80% of the way there because your coach is taking care of the rest on load. But do those things and you're probably golden. So strength training, hip internal rotation, managed load.
Steve, load. I think we started this entire podcast by saying the fact that we have ourselves and everyone in the ultra running community that just doesn't know how to constrain themselves.
Exactly. That's why I have a coach. I can help other people. I just can't do it for myself.
We try.
Yep. Your coaches have coaches. I have doctors and coaches for a reason.
When should a runner finally admit to themselves?
What should a runner?
When should a runner finally admit to themselves that they need to see a professional versus trying to Google MD it themselves?
Yeah, a couple rules of thumb. If it is staying for longer than what we would call natural history, which is 4 to 6 weeks, if it's staying longer than that, you have missed a puzzle piece. The body will heal things in 4 to 6 weeks. Bones sometimes take 8. If it doesn't heal, you're doing something that's pissing it off again. So exceeding that timeline usually is a pretty hard, go see someone. If it's affecting your training and your racing, obviously, if you qualified for states and you got in and it's in a month and you need to run, okay. The other more kind of esoteric part of it is a lot of us do this sport for the mental aspects. If this is something that you're dreading going out the door and it used to be your release, or you're in the run just constantly scared that your body's going to hurt in a way it shouldn't, you need to see someone. There's a safety net there, even if it doesn't feel that bad. If you have 1 out of 10 heel pain, but it's taking away your enjoyment of the sport, you're missing the point. So see someone for that too, even if it's not a a physical, like bad pain.
I mean, that's a fantastic answer. And it'll I think it's a great answer. It allows runners to really process it for the reason that they run. Like it's also the biggest fear we have.
Yeah.
Right. Because it speaks to the fear that we have about you're going to tell me I can't run. And yet the reason I'm afraid for you to tell me I can't run is because the mental side of it.
Yeah.
So like when you said that, I kept thinking, oh my God, like that's actually the reason they need to see somebody, not out of fear, they're going to be told not to run, but so that you can be aware of what you have and what to do about it.
Yeah. Yeah. And like the part of the reason I got into the field is I had so many injuries, and it was the classic, like, okay, take 8 to 12 weeks off.
Yeah.
And it's just devastating, right? I lost a couple NCAA seasons to very treatable stuff because they just told me to take time off. Like, you only get so many seasons in your life. You can do the sport for a long time, but you never know what's going to happen. So you got to, take it as you can.
I got nothing else.
I think it was great.
I mean, I had other questions, but I don't want to change that. Like, I just want to end on that note. So I'm going to
end on a high note, Jeff.
Well, an end on a note that I'm like, that's exactly the exclamation point that we want to kind of get for those who are listening. That's how you add that to your blueprint. Like that's what you do. And so that's why we did the podcast, is we want to help runners make the right decisions for their training and for themselves. And so, Mandy, thank you just so much for just your expertise, your knowledge, your patience, your kindness, just your humor. Like you make this fun. Like you make this fun on a topic that hurts, right? If you will. And so I know that's fun. But anyway, it's appreciated and really grateful you took the time. Really grateful for Sebastian for reaching out to us and telling us to connect and make this happen. And so thank you to him. For those listening, please reach out to Performance Place Sports Care. I'm trying to read it off my notes over here. We will have all the links at the bottom of the episode. Again, Mandy and her team have a website and they have a YouTube channel. They have a lot of great content out there that's free, but also you can reach out to them if you have questions that they'd be more than happy to. I believe, if I'm wrong, correct me, but I believe you can even get a consultation set up online. Yes. Or an appointment set up for something. And so this is available for anybody, regardless of where you live. And so I definitely encourage those listening, if you're interested in getting more information because you're toughing it out for something beyond 4 to 6 weeks, it may be time to talk to somebody. And so thank you for that. But again, listening, if we got something out of the episode, we just invite you to make sure you like, subscribe, tell a friend, tell somebody about the episode. We want you just to keep coming back and keep running with us. And so thank you for downloading the episode. And again, Mandy, thank you for everything.
Yeah, thanks for having me. This is fun.
Absolutely.
All right.
It was great.
All right, we'll see you. Thank you. Bye now.
See ya.